Okay, let's make a start. So thank you so much for joining today. My name's Tara Humphrey. I've got a few roles. I would say, like at the core, I'm a primary care network manager, but I also run my own consultancy where we provide interim management to other networks. We work all across the country. I've got a small team of people helping me. So people will say to me, how do you do it all? And it's like, it's not just me. I do heavily supported. I have a podcast called The Business of Healthcare, where we interview healthcare leaders. And we also, as kind of part of the business, we have a blog. The blog is like my fourth child. We absolutely love it. And that is our way of just sharing what we're learning about running primary care networks. And last year, we decided to create a series called The Role of the PCN ... And the goal is to be able to discuss, debate, showcase, and also highlight some of the challenges with all of the roles regarding within the primary care network under the additional role reimbursement scheme. But we also, obviously, we've covered the role of the PCN manager. And so next up is the role of the social prescribing link worker. And in my experience, and we run multiple networks, we've supported over 18 networks in a variety of capacities, and very few of those networks seem to have embraced the role of the social prescribing link worker. So I really wanted to do this webinar. I want to learn. I'm a big fan of the role, and I know what good the role can do. But I think in many areas, not all areas, but in some areas, I think we've got a long way to go. So the goal of this webinar is to basically hand it over to the experts, and the only goal is for us to kind of leave with some actionable takeaways. So I reached out to Sian. Sian, you're the co-chair of the National Social Prescribing Steering Group, is that right? Oh, you're on mute.
A great start, isn't it? That was in the middle of a cough. I turned that off. So yeah, so I am currently co-chair of the Social Prescribing Network. We have a membership from across the globe. So although much of our work focuses on the English model, actually it's the principles of social prescribing that underpin all of that we really focus on, and connection particularly to communities and the role of the voluntary sector.
Thank you. And we also are joined by Dr. Marianne. Marianne, if you share a little bit about your roles and your interest in social prescribing.
Okay, so I've been a GP for 36 years, and social prescribing is simply the best offer I have ever had to make my patients. It sees them transform from a life that is far from fulfilling their opportunities and strengths into a much better, more sustainable, resilient and happy place. So once I discovered this about 10, 11 years ago, I've committed myself to being as involved as I can to potentiating authentic, transformative social prescribing wherever I can, at the coalface, recruiting and supervising our own link workers, and strategically, regionally, locally, nationally, internationally, anywhere that anybody wants to know why it is the game changer for individuals and for organisations and for systems. I'm happy to be invited.
Excellent. So Sian, let's take it away. You mentioned that I suppose your organisation is all about the helping us to understand the fundamentals and principles of social prescribing. So what are the principles of social prescribing?
Okay, so the network actually came into being before the NHS model, and it was really a group of nosy people that wanted to know what was going on out there in terms of social prescribing. There were a few, schemes happening, Rotherham, Dudley, some down in Devon, and we started to gather a social movement, and that social movement led to working directly, the stars aligned directly with the NHS through the connection with Bev Taylor at the time to develop a sort of key model. And that Making Sense of Social Prescribing was the first publication of the Social Prescribing Network. It had a number of authors, all from different backgrounds, Dr. Marie Polly, Tim Amfilogoff, Michael Dixon and others, that identified three key elements to the social prescribing journey: the referrer, And eventually through NHS policy, we came about that referrer to begin with, because this was an NHS funded model, would sit within a GP practice, but within time could be from anywhere within the community, so not restricted to healthcare professionals, because it's all about connection and increasing social capital. Many GP practices still struggle with that. They feel that it needs to be from a GP, but actually what we're trying to do is reduce the demand on GP's time. So self-referral, referral from places like libraries, ambulance, voluntary sector, DWP are really important, so that we really get as early in that prevention space as possible. We don't want to wait until somebody's ill and they have to see a doctor to then get a referral on. The middle of this is the crucial bit. So it's a paid social prescribing link worker role. They may be known by other things, connectors, community directors, all types of things. But as long as you know what that person is called in your local area, it doesn't really matter, as long as that system understands what that role does. So that role is in charge of that transformative conversation with somebody. So this is the challenge for primary care here, is that GPs and their activity, and nurses alike, have very restrictive modelling around their appointments. And we've been crushed and crushed and crushed. The value in social prescribing is this is about spending time with somebody on what matters to them, not what is the matter with them. So it's about their priorities, their indicators for change, what they want to do. And this is the complete opposite to what the pathogenic medical model of the NHS is. Now, personalised care is about focusing on that person. So for somebody, it might mean one appointment with a link worker. It might mean a dozen. It might mean 15-minute, half an hour, an hour appointments. That personalised care approach is where you will get the value and transformation. Those link workers are trained. They're trained in coaching skills, motivational interviewing, active listening, and they also have a very detailed knowledge of the community and voluntary sector, in which they will be connecting that person to offers of support and help and activities, either during and along that course of those transformative conversations. So it's very difficult to have an algorithm or a formula for how to know how long somebody is going to need with a link worker. So it sits very challenging in that practice model. And I have to say, probably the support for PCNs and practices in understanding the differences between this pathogenic medical model that they're very used to and highly trained in, and this new salutogenic model where we're trying to upskill people, to educate them how to look after themselves, to know what's in their community, and release that dependence on the medical interventions. That they can be aligned and they sit hand in glove together, but we need to tell people how to do it. So that's the middle bit. The last bit around the framework and this sort of architecture for social prescribing is the community and voluntary sector. Now, these may be commissioned services like drug and alcohol, social care, but predominantly it's about the charities, the community groups that we can link to. Now, there's a significant risk here at the moment that integrated care systems need to look at how we fund and support the sustainability of this as social prescribing is becoming more embedded and successful. But essentially, it's been really successful in connecting people to the right place to go to. 25 to 40% of GP appointments are for social reasons, not medical, if we really dig down to the root causes of why they're attending practice. Now, can you imagine what that would free up if we had those social prescribers able to support people that were presenting with those social issues? And those social issues can be supported by a number of the voluntary sector offers that are around. So those three elements are the key architecture. The NHS funding for those link worker roles has absolutely been key from getting us to social movement to national policy. But our act now, our real action is to make it into a system-wide. How would we join everything together so we don't medicalise social prescribing by people not necessarily understanding the value and the opportunity that it brings for a community and for a GP practice?
I've got one. I've got lots of questions, but one of the things you mentioned is that you said they're trained in coaching skills.
Yeah.
Receive this training. Where do they receive this training? Because I know lots of people that are social prescribing link workers, and through no fault of their own, don't know what they're doing. They don't have that training, and they don't have the support.
Yeah. Okay. So firstly, I would recommend that and I've sent a list of a number of documents and links that will be really helpful. And I think Sophie may start to pop them in the chat box as well. So we have a set of guidance. That guidance was updated in June 2021, I believe. So it's ready to be updated again. We're just waiting for that. But it will tell you the job description, what's expected, the basic training, how to operate. All of that is in there. Now, these roles came in the middle of COVID, and quite rightly so, practices just didn't have the time to read it, but they were happy to take the role. So I think there's a bit of time needs to be spent going back over what they can do and what they're not to do. In terms of training, at the end of January, there were 3 NHS workforce frameworks published. I've shared the links with Sophie to pass on, each for the link worker, the coach and the care coordinator. That will have all of the expectations of training and career development and ideas. There is some mandatory training identified in the guidance that's delivered through the e-learning for health platform. Yep. So you just need to become a member on there. In addition, on that platform, there's a plethora of excellent additional training, such as making every contact count, mental health support, and lots of other stuff as well.
Thank you.
Yeah, so the training, you need to work with your line manager to identify your needs. That framework for workforce development will give you the sort of key areas to focus on in training. Now, the key training, like you've said, around the skills has to be funded by somewhere. I would go to your ICS and training hubs and see if that's something that your area would benefit from wider than just your PCN. And then in terms of the ongoing, it's not necessarily training. A link worker always needs to have a little bit of time in their months to update on what's in the voluntary sector. If they're not given that time, then their key role of connecting out to the voluntary sector is not going to be effective, and you lose that benefit.
Okay. Marianne, can you, on a very local level, what does social prescribing look like across your primary care network?
Okay, so we have 2 primary care networks who share one particular third sector host. So we have a fleet of 5 link workers across 2 primary care networks, and we are building that. I provide the clinical supervision for those individuals, and they can come to me at any time other than our supervision session. It's very important there is clinical supervision, because they do find themselves in the receipt of referrals that are not appropriate, and they feel a bit stuck, they feel a bit inhibited about going back to the referring GP and say, excuse me, but I'm not quite sure what I'm doing with this patient. So there does need to be that confidence, giving them to really integrate with their referrers, so that the referrals are absolutely made for the right people at the right time in their lives, with the other wraparound support that may be needed. It's important that the link workers are a part of multidisciplinary meetings, and that where there's an opportunity for a discussion for a complex individual or their family situation, that is facilitated. Our link workers are also supervised by a bigger umbrella organisation, and we encourage them to have as much peer-to-peer interaction as possible. They have a digital system, and they can see things on there that one another are sharing, other resources in the community that have cropped up. So it's very much an organic, dynamic thing. One point I'd like to make is recruiting them, because there isn't, like, as yet, a professional body of people specifically coming through. My experience is that link workers, it's almost as if it's a vocation, and something awakens within people who have been working with the public and seen the second mile that they could have gone if the criteria hadn't limited that, if they'd had a bit more time, if they had a bit more scope. And they're the kind of people who are very good at picking other people's brains and networking and building solutions for what looks like an insoluble problem. So you want to recruit them with that kind of energy, with that kind of curiosity. What more could I do if I were given the chance? And you speak to the rest of the fleet and say, who else do you think you need in your team as we recruit another? So my team said to me, we're having problems with housing. Please, can we have somebody with a housing background who will help us better interface with housing associations for the relevant clients? We're looking for somebody with a mental health training to develop a level of mental health specialism within the team, so that there's somebody that's an immediate go-to if there's just a question to be asked, not necessarily a referral to be made, maybe even a question about, is there a referral to be made, so that we make the best use of their time and expertise and enable them to help one another as they go and they grow. They are writing newsletters back to the primary care networks, because often by case studies and stories and explaining their own backgrounds and where they come from, they ignite the understanding of the referring GPs and the managing practice managers and the receptionists, who are increasingly picking up those individuals who may benefit. So we are trying to develop that conversation, that mutual understanding, and protect the service so that we use it appropriately. Where somebody would be able to be signposted, then we would encourage GPs and the practices just to do that, and not to call that social prescribing necessarily and take up the time of a link worker. You know, they have a limited capacity. We need to use it well. We need to make sure they are free to carry a caseload of no more than 30 for a 30-hour working week. It's approximately one person per the hour a week that you work on your caseload. The NHS suggested no more than 250 in a year. I mean, these are precious and vulnerable lives that you are coaching through a process of change, which you sincerely hope will be change to keep. So they need to have time to invest in those individuals and be supported by us and by one another to help make that difference. Does that answer your question?
Answered many questions. Can I just ask, in your network, I suppose, well, in your role, what are you saying to change, like GP's mind or practice manager's mind, where they go, look, I've had this role and I can't see the benefit of this service. I don't understand, I don't get it. Or for those networks that go, we don't need social prescribing in our network.
Okay, so there's enough evidence now to show that it does reduce the demand on primary care, even 25-30% of GP appointments that are no longer needed. It also reduces a similar flow into A&E. So even if that's all you are interested in, you need to wade into social prescribing. However, what I generally find is in any organisation, there is somebody that gets it. It could be the practice manager, it could be an advanced nurse practitioner, could be the carers champion. Whoever it is that gets it needs to become, as it were, an informal social prescribing champion within that arena, to talk about it and to publicize the stories. Because once people start to get a hang of some of the changed lives and they see people coming into the practice different, then it sticks. But it's getting to that point of realizing and feeling the difference that it makes to lives. I mean, I could tell you a couple of stories if you'd like.
Yes, please.
Okay. So the gentleman that I'd been seeing for about 10 years, and I'd been writing him sick notes of various vague psychiatric diagnoses, early 40s, out of work, no really good reason except he was bitter and let down in life. And he'd been part of a psychotherapeutic group. The psychiatrist had tried to pin various diagnoses on him, nothing stuck. And I should think a number of you will recognise that kind of individual. Broken relationships all round, and a life that just wasn't doing anything except feeling very bitter and twisted. And he did keep coming to see me, so I took the risk of asking him would he like a conversation with a new colleague on the block who may be able to approach his situation from a different viewpoint, not from the mental health viewpoint, not from the medical viewpoint, to have a different conversation. And indeed, he had a different conversation. Now, it took a while to build up trust. You've got to go through layers of cynicism and also what we call learned helplessness, which is the thing that underpins health inequality. That, why bother? Nothing's going to change. So the link worker conversation relationship started to enable this man to dare to believe something different was there in this relationship, and it was going to be long enough and in depth enough to get to know him as an individual. So he was prepared to invest his sense of risk, if you like, in that therapeutic relationship. And she referred him to a project whereby he started rubbing down furniture, recycling it, upcycling it, putting it into a shop window in the hopes that somebody would be interested in it. And as he's working on this physically, he said, you know, this is a bit like my life. It needs upcycling. You know, nobody wants me. And he was accepted onto the Building Better Opportunities Fund programme. Had to wait about 6 months, so we had to keep him warm during the waiting time. But when he got to the end of that, he had a voluntary option in a garden centre. Now, I was a little nervous because I thought he's not your automatically customer-centric individual. If anybody says something to him that upsets him, it might not go well. However, he took to it like a duck to water, loved the indoors, outdoors team approach. It just approached him in a way that had never happened before and was bringing him to life, plus he's rubbing down the furniture. And as he came back to see me in the surgery, he was visibly changing. Now, I have to tell you, he's like one of those guys that walks in, it's like a black rain cloud. And you're just like, oh, God, what can I do for this man? He came back, and when he smiled, it made me jump because he had a huge mouth. It went from one ear to the other. And I realized in 10 years, I'd never seen this man smile. He then was appointed permanently in the garden centre. He has restored relationships with his family. He is in a significant relationship. He's picked up his old art and he's doing things with his life. He is happy. I rarely see him now. The only time since I've had to write a sick note, and you'll love this, he rang me and he says, I've bust my ankle. I need a sick note for a bit. I said, what happened? Well, he says, I've become a sucker for karaoke. And well, it would have been all right if I only did the one song, but I stayed up for 3. And I was so elated by the time I got off, I badly twisted my ankle. Completely different human being. And I'd spent a decade trying to enable this man to change. Social prescribing does something that nothing else does. Sometimes it takes a time like that. Sometimes it's quicker. We sent link workers back with people that have been in and out of hospital. There was a gentleman that had been in for 8 times with crushing chest pain. Expensively and extensively investigated and sent back home. The link worker came to understand that what precipitated that chest pain was anxiety. So she says, may I get to know you a little more and understand what it is that makes you anxious? There were 6 or 7 things, some of them very practical, rails around the house, transport to outpatient departments, things like that. But the game changer was this. He looked across the room and pointed to a dilapidated sofa. And he said, you see that sofa over there? Me and my wife, we used to sit on that and hold hands. And somehow, whatever happened, we coped. Neither she nor I can get in that sofa or out of it anymore. So we sit on opposite sides of the room on dining room chairs and we worry at each other. Social prescribing link worker has this wonderful way of finding altruistic piggy banks, was able to fund just the right kind of sofa, and they sit in it and hold hands together. This man has not been back to hospital since. It's a game changer.
Okay. So, there's so many questions. I will try to get to some of them, but I just want to cover a couple of things. You mentioned, or one of you mentioned about reviewing the service. So for the people on the call, if you don't have a social prescribing link work, or you've not had a great experience, or you're looking to, you know, enhance it, where do we start when we're reviewing our provision? And you also mentioned, Marianne, you followed that patient and that you found out that he's not gone back to hospital. So what are the metrics? Because it's not that, it does need to be, or maybe it doesn't need to be, a little bit measurable. We want to know that this is making a difference. We want to know the impact. So where do we start when we review our service, Sian? You're on mute, Sian.
So at the moment, the guidance asks you to use an outcome measure, either PAM or ONS4. We expect that potentially to change in future to a validated tool of choice. I would highly encourage PCNs to join together across an ICB to choose the same outcome measure, so something that's simple. And I would suggest that PCNs train their link workers in how to use outcome measures consistently and regularly, so we can really maximise the use of this, because this is going to be one of your key evidence points in this coming year. So something like ONS4 is just 4 questions. We have others like the Wellbeing Star, which is also a useful tool to the link worker and the patient. And we also have things like MyCore as well, which is directed by the patient themselves. Okay. To use it consistently, you're going to start to see the outcome measures for the patient. However, numbers alone is not enough of a number to measure in terms of what we're doing, because this is about the value. So the value to the practice, to the PCN, to the doctors, will be about the number of appointments that they are saving for their patients. So this will need a very small in-house audit of link workers' activities set against the corresponding clinical appointments for those patients seen. So you could start small with one link worker across 50 or 100 patients over a number of weeks and see how that works. Obviously, the longer you do it and the bigger you do it, the more accurate picture you're going to get that's statistically viable. But we do know that where this has been done in PCNs and practices, they've demonstrated up to a 33% reduction in GP appointments for those patients that have seen a link worker and engaged in their support over a period of time. So it might be 1 or 2 appointments, it might be 12, 13, 14 appointments. But the corresponding clinical activity is definitely reducing. This is going to be the thing that I think is going to swing it for GPs and practice staff and managers looking at their workforce investments from 2024 onwards, when the money goes into their baseline. This isn't mandated by NHS England, so it's going to need some really savvy, astute, go get some link workers to say to their managers, look, we need to demonstrate what we are doing. Can we just try this small check of numbers to see what difference I'm making? I would also go for some patient satisfaction surveys. Yep. 2 or 3 questions, that's all you need. After you've seen somebody, how was it for you? So it's measuring the outcomes, the satisfaction, and what difference it makes to the doctors. Alongside that, I've always suggested and encouraged that we build those stories that Marianne has so eloquently described from a GP perspective. So they might be short paragraphs of quotes from patients, or it could be a longer proper case study story. That starts to say where you are now, but it's about building relationships with your local leaders, your GP leads, your clinical leads, your named GP for social prescribing and your PCN, your line managers, spending time with them, grabbing the time. And I know that's really challenging because they are so heads down in the crisis that they're in. But unless we start to give a bit of time to something like this and the other 2 personalised care roles, nothing is going to change, and things have to change, otherwise they will be done to us. And this is a huge facilitator in terms of shifting from that pathogenic model of health to working alongside a salutogenic model of health, where we, as a link worker works with somebody, they're skilling them up to do this stuff for themselves in future and not always be the default position of coming back to the practice. I can see that there's loads of helpful stuff being shared in the chat box as well whilst we're talking, so I'm sure that that will build a really excellent resource. This takes time as well, and I would say, and Marianne probably say as well, we've been saying you've got a year to prove it. Well, probably less than that, because you know we come around to March very quickly and decisions are normally made in the January and February. You have little time to prove your worth. We know it works. There's evidence out there showing now that it works. But you've got to swing your local leaders to say, yeah, we need you. And actually, we need more of you to do it safely and at a high quality.
Okay, I've got a couple more questions and then I'll open it up for Q&A. One of the things we had a discussion about, Sian, was the move to integrated neighbourhood teams. And I know in some areas of the country, it's like bread and butter and that's what they do. In other areas of the country, they're thinking, what the hell is an integrated neighbourhood team? One way of looking at an integrated neighbourhood team, I think, is from taking social prescribing as an example, is that you have your primary care network, you've got your social prescribing link worker, you may have Age UK, you may have an umbrella organisation hosting them, you may have local connections with community pathways and community organisations. Can that be an integrated neighbourhood team, or is that just people working collaboratively together? Marianne.
Okay, I think the critical thing is to find out who really gets this across your stakeholder relationships. There will be champions across your neighborhood that really get this and have got the energy and somehow have created the time to really shift this along. Those are the people to link up together. And it matters less where they are than what is going on in their heart, and that they connect like that. And then they can build around themselves an interest group, a stakeholder group, and you start to get a local steering group, which is led by people who are optimists and committed to it and are prepared to put in that va-va-voom to really accelerate it and to start identifying those black holes where people really do not get it at all. Get in alongside those people and bring them on. I think that is the only way to approach this, because we have an urgency. So if you on this call are here because you get it, I would suggest to you that you have a bit of a responsibility to carry this flame and be a part of what is happening in your area, whether that's a small area or a bigger area, to really effect sustainable partnerships and build it.
Okay. Somebody asked, they're struggling to know who to recruit. Is there a nice little crib sheet around who does what? Do you guys have that? Because I think some...
Do you mean who does what in terms of the other three roles together? Yeah, there is a simple one, but somebody suggested a webinar about how the three roles can work together, and I think that might be something nice to consider. I can share the infographic. I'll try and get it before the end of the session, but essentially they do different things, but they need to work together as a team if you've got all three of them. So care coordinator isn't about admin, doing extra admin roles for the practice. It has a real caseload management function around our most vulnerable, chaotic, disconnected patients, giving them some sense of direction within their care and health in their lives. They may refer between the coach and the care and the link worker. The link worker is around the social issues. They will use coaching skills for that empowerment piece, that motivational piece. But theirs is around the community, particularly in the social elements. The wellbeing coach is much more aligned to the medical instances. So their focus will be predominantly around long-term conditions, and they will be focusing on the gaps and the pressure areas for that particular practice or PCN's population. For some areas that may be heart disease, the particular issue, and for others it might be diabetes and obesity. And they will also hold caseload management. So you can see that there's a theme and a connection between the three. And for some, a good example, somebody's newly diagnosed diabetic and obese, and they're going to see the coach. Well, actually, they're also just lost their job, about to lose their house. They're not going to focus on their medical needs when so many social issues are going on. So you may see the link worker before and then be passed on to the coach afterwards. And Emma has very kindly found that infograph for me to share how the three works together. That's the start of that discussion. How it's arranged in each practice may look slightly different according to what other staff you have working. You may have mental health practitioners alongside that. You may have children and young people social prescribing link workers. So that's a guide of what they do and how they can work together. I hope that's helpful.
Okay. So there's some questions and some comments. Catherine says there is disparity between lone primary care network social prescribing link workers and the kind of the support they receive, the others receive if they're part of the voluntary service. Have you experienced that?
It's huge, isn't it?
Mm. Yeah. So the challenge is, obviously, when this was developed, we were very keen to work with NHS England about having the voluntary sector be a host of the link workers, because this is their speciality. They work in asset-based ways, they have knowledge of networks, they work in a very connected way in terms of what they're doing for this social perspective. These roles came in for primary care in such a challenging time of COVID. They didn't have a chance to understand what the opportunities were, and also they were new as PCN, so just evolving as brand new organisations, and given the opportunity of a new role, some are going to grab it, and if they're not open already to understanding potential relationships and opportunities with the voluntary sector, of course they would be inward looking in the middle of COVID and a new organisation as a PCN. So there has been disparity. We did have regional roles that tried to support those in that particular area. And we actually had for almost a year a PCN advisor, and I worked as one of those in the East. And it was about giving primary care networks a chance to understand the opportunities and how to develop a safe and high quality model of social prescribing. I think that's still a gap for primary care networks around education and learning. And, you know, to build some trust and understanding that there is an evidence base for this as well.
I don't think it's building on the question, but where you said we've got less than a year to prove its worth, and you've got some people that are really struggling. Do you think social prescribing is here to stay, whether we like it or not, or do you think actually if we can't demonstrate it's a fantastic intervention, they'll just say, look, we've tried it, other parts of the world love it, but we're not going to do it anymore?
Big risk, yeah. However, social prescribing being social prescribing can survive even that. It's about having a plan B in an area where, for instance, primary care may be focused on the biomedical approach to population health management, etc. It's not the end of the story. Then it needs the other organisations, the local authorities, the third sector, whoever it is that gets it and holds it, to come along and side and say, OK, we see that you are holding this aspect of our population. Let us hold this for you, and let us ensure that you have a place to refer your patients to. And then in time, you know, the whole thing will come round. There's an argument as should it ever have been put in primary care anyway? You know, was that a risk? And you can divide the room quite easily as to was it a good idea or wasn't it? We are where we are. Certainly, primary care has had the opportunity to understand it. If they haven't got it, I'd say, never mind, let's keep moving, because we have got time ahead, because I think there is enough sense within the whole nation that we need this. I think people have realised that the is not going to solve the problems of health inequality.
Succinctly, Marianne, you talked about clinical supervision. What is the role of the clinical supervisor? What do you discuss in your sessions?
Okay, well, we don't have a fixed agenda. We have some topics that we regularly, consider as part of the agenda. They kick off and they tell, well, not kick off, but they start. Well, they can if they want to. You know, it's their space to actually just to talk, and then I sort of pick up on the themes that are coming. You know, areas which clearly they've managed something really well, and we need to build it. Areas which they're actually showing me gaps. Difficult cases get discussed. Any relationships with stakeholders get discussed. It is an open time that, you know, we make sure that they are, you know, they're up to speed with their safeguarding and with their community development. You know, explore the areas that they might have forgotten are a part of their role. Support them as individuals as well, because it's quite a you know, a high demand job. And if they've also, for instance, got personal carer responsibilities, etc., it's important to bring into that realm a sense of care for them as an individual as they are caring. So it is entirely fluid, but very meaningful.
Lizzie asks, Marianne, what you're saying is fantastic. Please, can I ask you and others, what is your opinion on the impact and investment fund targets in relation to the suggested caseloads of 30 at one time and no more of 250 a year?
Okay, well, it's crazy, isn't it? Because it doesn't add up unless you've got an awful lot of social prescribing link workers, which was the original specification. But then, the other two roles came in, and then, we'd rather have a pharmacist, really. So there we are, without the numbers that we wanted in. So, you know, I think we have to continue to put that back to the centre and say, look, if social prescribing is going to be useful to us, it needs to be rich and transformative. But also in terms of counting numbers, probably what we need is better relationships with our third sector community partners to understand what else they are doing for our patients, understand also maybe what might be going on around the acute trust, and look at maybe counting other genuine social prescribing activity that is going on around our patients that we didn't actually instigate by referral. So I think there's something to be done around that. Sian.
You're on
You're
mute
on
again,
mute.
Sian.
I'm
Come on,
typing
Sian.
away for all of the questions.
Yeah.
I don't want the tapping to interrupt you. So yeah, I would agree with what Marianne said. It's a huge challenge. And again, if nobody understands this isn't about numbers, it's about value of conversations, it becomes a numbers game to get the financial incentive. And that just isn't social prescribing. It also came with the ambition from NHS England that this is about having the appropriate number of link workers in a team to meet that target safely. So it was meant to be an incentivization to recruit more link workers through the ARS funding. What it also doesn't take account of is a secondary but really important part of a social prescribing link worker role is also community capacity building. So they shouldn't necessarily, as an individual on their own, be spending all their time caseload. They should be out in the community, making needs for, you know, practice walking groups or a community garden, and working with their voluntary sector to really take these, you know, people that want to be connected, that want different activities that really we know are evidence to benefit health, to really, you know, make a difference to their health and well-being. And that wasn't factored in at all. So all we've got now with the IIF is a numbers game, and hopefully we'll come to the point where we'll have a much more appropriate target to meet. I mean, my suggestion was to get everybody to do the mandatory training in Health Education England's e-learning for social prescribing, so everyone has a baseline understanding, or at least 2 or 3 of the modules, that then we go, oh yeah, okay, get it now. How do we work together?
I think that's a really good idea. Okay, Emma asks, how do we as line managers, supervisors support our social prescribing link workers to achieve a balance between linking to and providing support to individuals? In brackets, quality versus quantity.
Talk to them. You know, that's just to have a relationship. If they're finding that they are so squeezed that they're not getting out and about, and bear in mind also that the third sector in communities is changing. I mean, premises that were open are now no longer open. You know, things have changed, so they do need enough space to be a part of that. and to know what's going on, and indeed support the voluntary sector, many of whom are feeling quite vulnerable in this. You know, they look to the link workers as allies and aids in their own work as well, and that community development, that, you know, we care about what's happening and we know the resource isn't great. Let's continue to work together shoulder to shoulder, so we put our limited resource in the best place, and so that we build social capital through relationship as much as we use the financial capital wisely. So talk to the link workers, make sure they have got the freedom for that kind of local innovation and partnership working. And where they're not telling you anything about that, that means you've sunk them too much in the realms of the caseload.
I don't know what Emma, I don't know if this is going to be helpful, Emma, or to anybody on the call, but in one of the networks that we supported, the balance between linking to and supporting was there was an issue around scope of practice and knowing when that person's role was to link and not to try to be, you know, like a therapist, try to be everything to that one person. So I think in the induction programs moving forward, scope of practice and having a GP deliver that scope of practice was really, really, really important.
I would agree with that, Tara, and also that sits then alongside the supervision. So, you know, starting to understand through that supervision, actually, that's where my practice should stop. And it might be a referral back to clinical, you know, clinicians if appropriate. And actually, that's the thing, the supervision and that scope that will keep that person safe.
So Kelsey says, absolutely support the whole ethos, aim and purpose of social prescribing. But if I'm being honest, I don't feel that many social prescribing link workers have been given the support and guidance to launch services in their areas, particularly PCNs. I understand the role to an extent, but no one tells you how to actually implement it. She's just sharing her thoughts, and I think this is one of the reasons why we're doing the webinar. There is loads of resources, and there's no, in my experience, there's no shortcut. You do have to, you know, like you have to read the guidance. You need a few people to read the guidance and the tools to say, like, oh, what do you think, or what do I think it means this, I think it means that. You start small, you select your cohort of patients, and I think, and we've done this with our care coordinators, making sure, you know, like, is the role wanted? I would much rather my network not have any role if it's not wanted. If you have to fight tooth and nail with putting that person in a really horrible environment, is the role wanted? Have we got some sort of shape, you know, like some sort of service? Is there a process for referral? Who is going to be the support? What does the support mechanism look like around that person? Who's a clinical supervisor? What does their induction look like? Have we got our practice managers on board? And I think that it takes time. I wish I could say, here is the framework, follow it to a T, and you'll always get the best outcome.
Yeah. To be very honest, I would also say I wouldn't expect a newly recruited link worker to set up a service. So I would say it becomes, like you say, that team responsibility. So your line manager, every practice should have a GP social prescribing name lead. Every PCN should have a social prescribing lead as well. Now, we know that doesn't exist in most places, but how to change that starts with conversations. I would agree, start small. You know, look to others. There is a national social prescribing platform. There's loads of stuff there that people share. So it's never you're going to be starting from scratch. There's some really great principles. The guidance is a really good starting point. The mandatory training helps. It's all about relationships, not just the relationships a link worker has with their patients and the community, but starting in your own organisation. Get to as many meetings as possible. Find your connectors, your people that get it. It might not be that they're the leads, but actually they have the connections and the understanding of how things work in your practice and how to, you know, get change happening. And it takes time. It really does take time. Behavior change and culture change is not an overnight thing. But I would say if you're starting around now, focus on those numbers as soon as you can to start to build the evidence of the difference that you're making. I also work in helping systems to develop their social prescribing systems. So if we can help you, Tara, in any way in helping your practices, Mary and I are just finishing some work in the east of England. That PCN advice role is exactly what's crying out for in the chat box here.
Yeah. Okay, well, you're going to be inundated. I don't know how you're going to manage it all. I just want to bring the conversation to a close in regards to, you know, like the numbers and targets. Well, I know some networks that fully embrace the notion of social prescribing, and because they experience the value, they're not going, you know, what's my case, you know, like they're not, the social prescribing link worker is not working to this hard target. So it depends on how you view the role. Sometimes it's nice to have a bit of guidance, but I think, like with all services, you shape it to what matters to your network, but not be so over reliant on the numbers, because it's not like they can't just sit there and just, you know, like, you know, bang out these referrals. So I would say in some networks they would be surprised to hear the target, because they think, oh, we don't do
it's
that.
not a priority for us. We don't need it.
I think
we value the value of social prescribing,
and I think if we work to the outcome measures, if we work to what we are trying to achieve, and yes, we're trying to save appointments, but it's more than that, then that may shape the conversation. But as you said, there's change management, there's OD here, and I think sometimes we forget. I mean, there's OD with all of the primary care networks, and I would say, I know this webinar is about social prescribing, but in all of these webinars, every role is going, you know, like they don't understand my role. They don't value me. I don't have clinical supervision. I don't have support. All of the roles in many cases feel like that. Okay, we are rattling through. Let me just have a look at the chat. Oh, if any of you guys can see some questions.
Sorry, I've probably hidden half the questions with the links that I've just put in that people have been asking for.
Gosh.
Yeah, so nice to have Scotland here. So Ruth Ann Baxter's here, and she said she's been leading on prescribe culture at University of Edinburgh since 2018, and she said now it's only just starting to gather traction. And that's the same, you know, there was a Twitter post yesterday from somebody with a BMJ, just a discussion paper that said, is it too early now to understand whether social prescribing is embedding and evidence-based? You know, if this is about culture and behaviour change, this is going to take some time, and some of the evidence says it can take up to 8 years to be able to understand this. Are we jumping the gun beforehand? So Ruth Ann says, you must remain committed and know it will be a slow burner, but focus on the difference it makes to the individual. So all of this about serving our patients, this is public money, this is NHS service, free at the point of delivery. We must serve our patients. And if they're presenting with social issues that stop people with clinical issues getting their help, then this has to make sense as a fundamental change to the NHS to support its continuation.
Okay. I think we can, Jennifer Neff is here. Jen, I can't read that message. It's too long, but hopefully you guys will check that out. Okay, I'm going to start to bring this to a close. I think it's been so helpful. I think this has probably been one of our most popular webinars, and given that all of the engagement, make sure you contact Sian and Marianne if you guys need support. I know there is a National Association of Link Workers. I know there's the Personalised Care Institute. They've got lots of resources. There are, I think on NHS Futures, there again is a section for personalised care
as well.
There's lots and lots and lots of support. You might so I think it's just about identifying what would be like your next best step. What could we do from this webinar? What actionable step could you take? And everybody's in a slightly different scenario, situation. And I think, only you guys can decide, and maybe Sian and Marianne might be able to help you identify what your next step is. I think for me personally, I think reviewing the service, I think in one of our networks, they no longer have a social prescribing link worker. So I think, but they recognise they want to do something different. So sometimes, like if it doesn't work one way, you can try to do it the same, or you can try to do something different so you don't get the same result. We've got lots of lessons learned. So we'll definitely be reviewing, and we'll definitely be looking at the outcome measures. I think you want to start with the end in mind. What do we want to achieve? What are the lessons learned? What's our infrastructure? What support can we provide? And then what sort of person do we want? That is what I'm going to take from this. So if you can leave us with some final motivating, inspirational words, that would be amazing. If we start with you, Sian.
So I would say keep doing what you're doing. I see the struggle, I hear the struggle, but in terms of what you do, it does make a difference for your patients, for the people that you're working with, the communities that you are connecting to. So for me, everything that you do is increasing that social capital, so connection between individuals and their community and communities and community. So social capital is really important. We know where social capital is increased, health and wellbeing outcomes are generally much better. So just keep doing what you're doing. Do connect with Marianne and myself. We're here to help. We do have experience, and we also have connections across the country that we can put you in touch with if we need to.
Definitely.
Thanks very much, Tara.
Marianne?
Okay, I'm going to close with remember the health and well-being of your link workers. I think we have in our midst change agents that we have to nurture. These link worker roles, we could lose them. And if we burn them out or misdirect them or misappropriate them, we will lose them, and there won't be enough of them. And it would be an absolute tragedy if we look back and say, do you remember that workforce that we used to have that made the difference? I think there's a real urgency at primary care network level to look and see, are your link workers okay? Are there enough of them? Are they receiving the right supervision, the right training? And are we loving them and trying to protect them? Because it's a tough old world out there with, people, not enough money to do things. People's lives are in more of a mess than they were. The third sector organisations that they're referring them to have got less capacity than they used to have. It's our link workers in the middle of all that sense of deficit. And what we are trying to build is a sense of possibility and scope. So if we don't protect them, it will be very hard for them to make a way where there is no way and make it happen regardless, which they will if we look after them.
Hear, hear. Thank you so much. I think that this has been the most engaged chat, which shows unfortunately just the support that's needed, but there is support out there. But I think another takeaway would be for me is that organisations like yourself, and even organisations like THC, we can give guidance, but sometimes you need a conversation. There's reams and reams and reams and reams of guidance, but actually you might need a webinar, or you might need a small working group to come together to digest it. But there is support out there. So thank you so much. And we will definitely do the role of the care coordinator and the weird and all wonderful ways that role is deployed. And I definitely will look to do a webinar which brings the care coordinator, the personalised care roles together. I feel like this webinar series will just keep going on and on and on. Okay, thank you so much. See you later, guys.
Thanks, Tara. Thank you.